Dr. Rozhatsky, welcome to Belgrade, and please, we would like to hear your talk.
Thank you very much.
Good afternoon, ladies and gentlemen. I'm sorry I'm late, but you know it was the Polish Airlines and the young pilot, so he promised mother to fly slowly, and we went 40 minutes later. But first I want to say thank you very much for an invitation here. This is a great honor for me to be here and to talk about my experience with the treatment of venous reflux diseases. And actually, I'm really glad to be here. This is not my first time in Belgrade. I was many times here, many years ago, and some years ago, and always I said I love to come back here. I like the atmosphere of the Belgrade, of the streets. I like to talk with the people here in the small restaurants, in the shops, and I thought that maybe this is the kind of the Slavian soul, the same for both of us. But when we are looking to the history, we can see that it's not only the soul, but some historians believe that the White Serbia, the mythical homeland of the White Serbs, from whom the medieval Serbs originate, was located on the center of today's Poland. And in the 7th century, they moved to the south to form the modern Serbian country, and left the territory that we are living now, we Polish. So maybe in 7th, 8th, 9th century, really the Serbs founded the first Polish towns and first Polish capital in Gniezno. The history is exciting, of course, but going back to the topic, I want to start with the history also, because if we want to answer when do we stand in 21st century with the currency of the superficial veins diseases, we can also answer where did we stand in the 20th century. Look, the 20th century was the age of the dramatically rapid technological development. We start the 20th century with balloon travels and finish with the spaceships. But when we look to the history of the phlebology, we have the end of the 19th century Friedrich Trendelenburg idea with first crossectomy and removal of the femoral segment on the great saphenous vein. And this method still exists. Some years later, Dr. William Wayne Babcock showed the first stripping with flexible special probe passed through the lumen of the veins, and the method still exists. And the first parvectomy, it was almost 50 years ago. So Dr. Robert Clinton, 1957. So this is the history, but really not so many changed during the 100 years. We have the new technologies, but we cannot apply these technologies to the surgery of superficial vein system. So what really changed the phlebology on the end of the 20th century? It was of course, ultrasonography. The ultrasonography applied to the treatment investigation of venous system gave the chance to know better anatomy, especially that we have the individual anatomy of the superficial vein system in each patient, the physiology. We start to understand the pathophysiology of the reflux. We start to understand the role of the perforator veins. We can control the procedures, especially the endovenous procedures. And we have the great tool for the postoperative control. Does that mean that it's the end of 20th century, this is the end of the blind open surgery? I think not at all. But the introduction, this minimally invasive endovenous procedures completely changed the treatment of incompetence of superficial veins of lower limbs. We have the different new methods from the classic sclerotherapy through the catheter-directed ultrasound-guided sclerotherapy. Finally, the last idea with the glue-based vena-seal ablation system and diverse form of thermal ablation using laser energy, steam, or radio frequency waves. So when we try to review the methods, we can say we have two main groups. First, the thermal ablation with the older one, endovenous laser ablation, with the idea of the French surgeon Dr. Miller, endovenous steam ablation, and to the radio frequency powered segmental thermal ablation known as a closure fast. and chemical ablation, old sclerotherapy, with the ultrasound-guided foam sclerotherapy and new devices like Clarivane, that we combine two methods, the chemical and mechanical, I will tell about it later, and the newest method, the Venasil superglue. We don't use any anesthesia, we don't need any special equipment for that. So when we ask what we expect from these new methods, we must look to the open surgery, and we can think what kind of disadvantages we don't like. We don't like manually remove the vein segment from the legs. This is a brutal method. These methods usually require the general spinal anesthesia. It's not at all because we start to perform the classic surgery with the local tumescent anesthesia, but in most hospitals still exists the spinal general anesthesia. The patients suffer for long incision scares, for extended post-procedural discomfort and wound care. And they usually don't like the compression stockings. For us, as surgeons, it's important that the injuries and hematomas caused by stripping leads to new vascularization and recurrency. And both surgeons and patients expect that the new methods give us the chance for one-day surgery, for the even lunch break surgery. And, of course, we expect to reduce the side effects and complications after operations. This is the list of complications: discomfort, bruising, hematoma, bleeding, lymphatic damage, femoral vein and artery injuries, wound infections, injury of the saphenous and sural nerve with permanent nerve damages, symptomatic and asymptomatic DVD, and postoperative discomfort. And we cannot, of course, reduce all these side effects, these complications to zero. There is no method in surgery with 0% of complications, but we can reduce it. And this new method must give the chance to reduce it at all. So, the most important, I think, for surgeons is, of course, the sufficiency of the method. We don't want to observe the recurrences, the residual veins. We don't want to see the complaining patients for the new varicose veins. If we look to the previous older trials, this is from 2004 and 2003. This is the Costas trial, and they concentrate only on classic open surgery results. We have the 5 years follow-up with 28% of recurrences. There's some of these recurrences caused by new vascularization, some new varicose veins as a progression of the diseases, some residual veins as a technical or tactical error of the surgeon, and some complex patterns. In another study, we have even the recurrences on the level 51%. So we want to find a much more sufficient method. And the question is the newest endovenous method are giving us the chance to have the better results. Let me look. Endovenous laser ablation, the first method, like I say, the laser generator emits light which is transmitted to the tip of the fiber. This light energy is converted into heat energy. And of course, we destroy the wall of the vessel. It leads to the inflammation and to the cicatrization. We can completely and permanently close the vein. We have only some problems with the endovenous ablation because we observed the rapid development of the methods, new generations, different laser wavelength, different tips of the fibers, and the results are coming better and better. And with the thermal ablation by laser is one problem also, that this is a quite long curve of the learning, because the energy required, we must depend on the dimension of the vein, the laser wavelengths, the power we are using, and the fiber type. If we use too much energy, we can burn the tissues. If we use not enough, we have no ablation. But when we look to the results, this is the classic Rasmussen study randomized clinical trial with comparing the 4 different methods, the occlusion rate after 5 months is more than 93%. It's, I think, really good results. When we look to another, the Miller idea with the veins, steam vein sclerosis. This based on the, we inject pulsed steam of the warm water to the vessel, and the steam condense at the end of the catheter and transmit the heat to the wall with all consequences of the heating of the, destroying the proteins, the wall of the vein. And the results, these results were published by Miller. After 1 year, it was 83%, not so much, but it was 2010. It's still, during the last 8 years, he changed the method, he changed a little the procedure, and the procedure is much more sufficient now. But this method has not so much data. The arguments are quite weak, so I know many surgeons using this steam ablation, but we have not really a good data about it. And the third method from the thermal ablation, the radiofrequency ablation. This endovenous ablation is well-known method. From 2009 till now, it was performed more than 3 million of procedures. Of course, when we try to compare it with the laser, I'm sure with the laser it's much more than with the radiofrequency. But we know from the producer how many catheters he sold till now. So we know that was almost 3 million. And in radiofrequency, the power is automatically adjusted by generator to keep the constant temperature on the heating element at 120 grades. We have on this heating element the heat sensor, and we have the feedback to the generator. So we don't, it's not necessary to know how much energy we want to apply. The computer and generator do it for us. For us, it's important to insert in the right position the catheter and to make the tumescency well. And but the results are completely the same like with another method. This is from the classic Dr. Krebs study with 5 years outcome, and this is the results, the occlusion rate after 5 years, almost 92, and the reflux-free rate, almost 95%. Maybe a little better, but statistically, it's not any differences between these methods. So, coming to the chemical ablation. Of course, we have the classic sclerotherapy. We start to use the catheter-directed sclerotherapy. We combined sclerotherapy with the tumescency because we want to remove the blood from the vein before we apply the sclerosants. But this is another idea, to join two methods, the mechanical and the chemical. First, we have the scratching element, which is scratching the erythema and make it more sensitive for the sclerosants, and it involves the spasm of the vein also, so we have the vein free from the blood. The occlusion rate, it was quite a new idea, but the first data show the comparable results like with the other methods. We have the 2 years follow-up now, and method is about 95% of there is rate occlusion. And last idea start to be very popular. This is the super glue Venasil closure system, the medical adhesive. The producer cannot use the word glue, we must use the medical adhesive. This is not tumescent, not thermal, not sclerosant procedure. We use the special adhesive and we deliver it by the special system of the device, special device to exactly to the place we want to close. And by pressing the vein from outside, we just fasten 2 walls. After, we have the inflammation reaction and we have the fibrosis and completely permanent closing the vein. This method not need any anesthesia. We just puncture the vein we must control the position of the catheter inside the vein. We apply the glue, and that's all. And we have the first three first three studies about this, the sufficiency of that method, and it showed the comparable sufficiency like the another endovenous method. And as we see, we have the many different methods. We have quite the same sufficiency. So the question is, we must apply all of these methods to our everyday practice. All these methods are friendly for patients. There is no significant pain during the procedure. Of course, the thermal ablation needs the tumescent, to apply the tumescent liquid. So patient can suffer for that, but sometimes we use the anesthesiological support to make more comfortable the treatment. After procedure, there is no significant pain, and the patient usually don't need any analgesics. We have the high efficiency of ablation, and we have rare side effects and complications. Of course, talking about each of method, we can talk about them some specific details, and they are a little different in many ways, but it's for the really a huge discuss. But this new method requires mastering a new surgical techniques. Especially, what's the most important, needs the ultrasound skill set. This is essential if we want to perform this procedure. So, if we think where do we stand in 21st century, the answer is we have the many different methods. Now these methods are developed so fast, so even it's difficult to check are all really sufficient and safe. But we must be ready to prepare the new training program for surgeons, especially with ultrasonography, but not only. We must master various surgical techniques. And the future is that we must fit the method to the individuality to each patient. It depends on the anatomy of the veins in each patient, and the decisive factors are, of course, our own experience also, the patient preferences, and the third and really important thing, the financial abilities of the patients, because most of these methods still are not reimbursement. They have not reimbursement. They are not covered by the national funds in most countries. So finally, I can say like that. I can quote the old ancient Roman poet and sage Ovidius. He said that, maybe I will not translate exactly, but he said that whatever we are doing, you must do it wisely, and you must watch the end. If you want to translate it to the phlebological language, we can use the sentence which prescribed Dr. Michel Perrin, the founder of European phlebology. And he said that the problem is that development of new procedures or devices is so rapid that when long-term outcomes are available, particularly from randomized clinical trials, the technical material evaluated is frequently no longer used. So what does it mean? We must watch carefully, and we must decide using the brain, of course. Thank you very much.
Thank you, Professor Zakatski. Do we have any questions from the audience? Usually in medicine, when we see so many methods for one pathology, we say that none of the methods is so good because we have a lot of methods. But here, from your presentations and from other presentations, it doesn't look like that. What do you think?
No, I think it's, we can, partly this is true, because we see that it's an ambition of many surgeons to try to find something new. We have this new technologies, we have ultrasonography, we can just, the last 20 years, method is running after the method. So on this way, it's true. But from the another side, when we are look carefully to each method, we can see the advantages and disadvantages of each of them. So if we, like I told before, if we feed the method to the patients, for example, we can close the main insufficient saphenous trunk to the level of the knee, 1/3 lower than knee. And we have the problem with the lower part because we know we have the contact with the nerve. We don't want to destroy the nerve. We cannot use for example, the thermal ablation, but we can close the lower part by ultrasonography, by sclerotherapy under ultrasound control. So we can combine methods for more sufficient and more safe treatment of the patients.
Thank you. If we don't have any more questions, on behalf of Serbian Society for Cardiovascular Surgery, I would like
Thank
to
you
give
very
this present as a memory of your visit here, and we'd like to see you more here in our facilities and in our meetings.
That's a great pleasure and honor to be here for me. Thank you very much.